Let's get started. I want to bring on Jennifer Heimel. Did I say that right?
It's pronounced email, but that's okay.
What is
Don't worry.
it?
It's pronounced email. The H is
Well,
silent.
that's
Do
fancy.
not worry.
I love it even better. Jennifer is a NICU nurse practitioner, and she's going to explain what the heck that means and what the difference is between a nurse and a nurse practitioner. So, before we get into the nitty gritty questions, I'm going to have you tell us a little bit about you and how you got to doing what you do and where you're from.
Thank you for inviting me to be here. I just want to introduce myself real quick. My name is Jennifer Email. I'm a nurse practitioner in the NICU. So I was previously a NICU nurse. I did that for about 6 years. I went for my graduate degree at the University of Virginia, and then I've been a nurse practitioner in the NICU for about 2 years now. So I really have enjoyed kind of a change in my role, but I've always loved the NICU, which stands for Neonatal Intensive Care Unit. So we take care of sick babies for all kinds of reasons, whether they're preterm, term, some babies who do have the neonatal abstinence syndrome, or the babies who are withdrawing, which is what we're going to talk about today. So we see lots and lots of different cases in the NICU. It's not just preterm babies, which I think a lot of people, that might be their idea of the NICU. So yeah, I live in Northern Virginia, and that's my current role, is a neonatal nurse practitioner. So Becca was wondering, what's the difference? So you may have heard of like a family nurse practitioner or a pediatric nurse practitioner that you may have seen either for your care or for your child's care. So you may be familiar that we function independently. We work more with like the medical team. So when you think of the hospital, you've got lots of different people: the respiratory therapist, the nursing team, the medical team. So as a nurse practitioner, I work with the medical team. So we work really closely with the physicians, who in the NICU are the neonatologists. I tell the parents they're the baby doctor. So we work closely with them. So we're kind of writing like nursing orders and coming up with the plan of care for the day, updating the families. So it's just a little bit of a different role, but I do have experience as a bedside NICU nurse as well. So dealing firsthand taking care of babies who are going through the withdrawal. So I can tell you more about that. I previously worked at Georgetown University Hospital, so I was in the city, and you'll notice we'll talk about NAS, which again is neonatal abstinence syndrome. I'm just going to say NAS, but it's the withdrawal. So it's very like regionalized, I guess you could say, where we see it kind of in pockets. So for Virginia, we do see a lot of babies going through NAS, like in the Richmond area, even in like the southwestern Virginia area. So it kind of just depends like what hospital you're at. So I definitely saw it more when I was in DC. We actually got a lot of babies from the southern Maryland area. So, unfortunately, areas where there is a lot of drug addiction, and then we do see people who go to like methadone clinics, things like that. So, hopefully, that is a brief introduction. I'll try not to talk your ear off, but Becca, if there's anything else you want me to address, let me know.
Thanks for that. Let's dig in. First question I'm going to ask, and then we'll kind of get into the nitty gritty of what I know you're all kind of waiting for. But this is all really good information, because when a baby is born, is it standard to test all babies no matter what for drugs? And what does that look like?
Yeah, that's a good question. So I would say it's definitely going to be hospital specific. So if you end up in a hospital where there are typically a ton of babies who end up with the NAS, the withdrawal, or it's just a known area to have a lot of people who are drug addicts or a lot of people going to the methadone clinic, I would say that their policies would be different than another hospital. So I feel like I've heard of, Baltimore area, or even there's a hospital like 45 minutes from where I am, and they screen every baby and every mom. So, excuse me, it might just be different per hospital, but typically, like at my hospital, we do the drug screening. If the mom did not get any prenatal care, that's just one of the things we do. It's kind of an umbrella where we do a lot of different testing. If the mom got no prenatal care, we do drug screening on the mom and the baby. So what that looks like is that we can test the mom's urine, and then for the baby, we can test their urine and their stool. So you may be familiar, their first stool is called meconium. And so it's like that thick, tarry stool. It's kind of gross. But that has been developing in their gut when they were in the womb. So that gives us actually long-term information, multiple months even. I can't tell you the exact amount of time, but basically the meconium has been in there more long term. So if that comes up positive, we kind of know that it's more likely to come up positive than the urine because it's been there for longer, if that makes sense. So we can screen their meconium to see, we call it a toxicology screen. So we can test for all different drugs to see if it's positive and the baby has been exposed. And then we can also test their urine. It's just the urine tells us a more short period of time. It's not telling us long term. So I believe the mom would have had to use that drug within a few days, more than likely, for the baby's urine to come up positive on the screening.
Interesting. Okay. And what are, if they are exposed, what are some of the signs a baby exhibits
Yes.
if they have been exposed?
Yeah,
And does it
definitely.
differ with
Yes.
different drugs? Yeah.
Yeah, so it depends on the drug, and we might not always know exactly what drugs the mom was taking or how much, and so we just see a lot of variation, and different babies, I'm sure, react just differently in general. But certainly if you're having a higher dose or much more exposure, you're typically going to have more signs and symptoms of this NAS or the withdrawal. So I'll kind of explain what that looks like typically just in general, but it is a broad spectrum. But we just think of CNS irritability. So CNS is central nervous system. So I'm trying to like show you my hands because I want to show you what they look like. Like their muscle tone is really tense and tight. So their whole nervous system is like just overstimulated and irritable. And so the babies themselves are irritable. They have this really tight muscle tone. They might be crying. They oftentimes will get loose stools and diaper rash. Um, so overall, they just kind of seem like an overstimulated baby. There's other things that we will see: excessive sucking, like they just want to eat and eat and eat all the time. You have to cut them off because you're like, you're not hungry. You just want to suck and eat all the time because you have this excessive sucking. Another thing, when the nervous system is irritable, they'll be like sneezing. And so you kind of think of an adult. Personally, I don't really think I've seen many adults going through drug withdrawal, but like you see it in a movie or something, and they're like sweating, their heart rate's going fast. So it's similar. It's just, it's in the baby. And we do our best to help them manage the symptoms in various ways. So Becca, that kind of ties in here to talk about like what we do about it in the NICU. You want me to kind of get into that a little
Yeah,
bit?
sure.
Okay.
What are you talking about? What can parents do to help?
Yeah,
Yeah.
so just typically what we try to do is non-pharmacologic. So basically what that means is we try to always not use medications if we can to manage. And there's even special facilities that are just for these babies. So non-pharmacologic things we can do to help them when they're in this state of kind of like hyperactivity, everything's just irritable, the nervous system's just irritable. We want to try to bring them back down. So that means like a dark, quiet environment. You could do like some white noise, but you really don't want like, music or overstimulation. They're already just overstimulated, so you're just trying to make it as calm as possible. Giving them their pacifier. They really enjoy sucking, and that's super soothing for them. So that's a good thing. I know every now and then some, lactation consultants or whomever, like people can be anti pacifier. Not in this case. We are not anti-pacifier. We love that for the babies because it's super soothing for them, and you'll notice it helps them to just calm down. So, and you kind of want to like maybe put their hands in some mittens too because they've got their hands up near their face. They might scratch their face. We talked before about they might have loose stools just because their GI tract is all out of whack. Just like if you're going through a stressful circumstance, your GI tract is impacted. Everything's connected in the body. So managing that diaper rash so that that's not causing them additional pain. So always these non-pharmacologic measures. So holding them, rocking them, but not overstimulating them. Like you don't want to be with any newborn in general. You don't want to be overstimulating them. People want to talk to them, get them to like smile or open their eyes. You don't want to do that. You just want to be nice and calm. So rocking them, they really like that soothing swaying motion. Holding them nice and tight and close, keeping them in a swaddle so that they're not having those frantic movements. Because these kiddos, I mean, a newborn in general, they'll startle themselves and wake themselves up. But these babies, they have a hyperactive moro startle reflex. So they really flail out, wake themselves up, and then they can get into a tizzy and just spiral and not be able to get it back together. So just trying to keep them in that calm state, keeping them swaddled, just helping them to feel kind of organized, collected, calm. Those are all of our measures that we take in terms of non-pharmacologic.
Did
There's
you already say skin to skin?
skin to skin can be good. I don't know what the research is in terms of the baby's going through withdrawal. I mean, you could try it. They might like it, but one of the main things I know is they need to be like swaddled and contained. So that's the only
Mhm,
thing when you're doing skin to skin,
mhm,
they're not usually
right.
swaddled and contained, but some babies might really love it just to hear your heartbeat and your breathing, and that might be really calming for them. They might, but other babies, they need to be in like that tight swaddle, and
Mm,
that's like their happy place. So, um, yeah, so that's what we do non-pharmacologic. There's a program called Eat, Sleep, Console. So that one is focusing on, can the baby eat well and can they sleep and can they be consoled? And that's the whole program is to do that and use a scoring system based off of how they're doing with those measures rather than kind of the older way of doing things is we have this like Finnegan scoring system. So we look at them based off of what signs they're showing, we come up with a score, and then that determines do they need medication? Do they need like more medical intervention? So the goal is we don't want them to get to a point where it's unsafe, of course. So the worst case scenario, if they're really, really having terrible drug withdrawal, would be like if the baby were to have a seizure because they're just so
mhm,
irritable within their nervous system. So we always want to prevent that. So if it's getting to a point that they're just absolutely miserable, they can't even feed, they can't collect themselves at all, we would give them morphine, would be the drug of choice typically. And their second line options if it's refractory to that. And you give them whatever dose they need to get them to that calm place and get them collected. And then they usually stay on that dose for a couple of days and then you try to turn it down. So every day you're cutting them back a little bit, a little bit, a little bit each day as tolerated on that morphine dose with the goal of getting them off of it entirely. Again, it's not always morphine, but that's typically kind of the first line at this point in time. There's other things we can use as adjunct therapies as well. But like I said, we always try to do the non pharmacologic first, and that's the goal is to not have to introduce any sort of medication into their care plan. However, safety is the top priority. So if the
mm.
baby is, anybody can see if this baby's just they can't feed, they can't collect themselves, they're absolutely miserable. At that point, you just need to support them how they need, which would oftentimes be giving them morphine typically. And then you just cut it back a little bit each day.